officially live. Hello, everybody. Thank you so much for joining us today. I am Deanna Bryan, Program Manager here at Hope for HIE. We are also joined by Betsy Pilon, our Executive Director. She's off camera at the moment because she's going through a cold, as I'm sure many of you are at this time of year. We are so grateful to have Dr. Atul Malhotra with us today. He is a neonatologist at Monash Newborn, Monash Children's Hospital, and he's also a research academic at the university there. Thank you so much for joining us today to talk about cell therapies and the role it has in understanding and treating HIE. And I know we're also going to talk a little bit about early detection measures for cerebral palsy. So thank you so much for being here.
Thank you for the invitation. Very happy to be here.
Thank you. Before we get into the questions, I'm hoping it's okay if you just want to introduce yourself, maybe give a little bit of history about who you are, where you are, and what you do, and then we can get started.
Sure, Diana. So like you mentioned, I'm a neonatologist. So I work part-time in the neonatal intensive care unit at Monash, which is in Melbourne, Australia. And I'm also a research academic, which means that I'm funded by our National Health and Medical Research Council in Australia to do research. And my research focuses on what is called perinatal brain injury mostly, which is brain injury acquired during the gestational period, around the time of birth or soon after. And obviously HIE, which is the main focus of Hope for HIE, is one of those types of perinatal brain injuries.
Attention, please.
Wonderful. Yes. I know that he said that he's going to mute himself anytime there's he's at the hospital right now, and overhead announcements, of course, the timing of which, you know, is fine. And I said it's no problem because you're all going to hear my 3.5-year-old screaming or my dog barking. So it's okay. That's life, right?
Yeah, so just to continue on where I left, my area of research basically focuses on perinatal brain injury. And in particular, we have a neonatal cell therapies program. So we have cell therapies, which we'll discuss more about soon, for a number of conditions in the newborn infant. And we focus both on preclinical and clinical translation.
Wonderful. Well, thank you so much for your work. And your research, and just from our community, we were talking to Betsy, and she said when it comes to stem cells and clinical trials and everything related to it, it's a very nuanced topic, and there's a lot of misinformation out there, especially in the US. So it's really nice to have an expert kind of guide us through those waters. So to begin, I think it's best if we just lay a foundation, and if you could explain to us, what are stem cells?
Okay, so I think that's the very important discussion to have right at the start. So stem cells, the true sense of the word stem cell has a cell which is generally derived from the human body, which has got two properties. One of them is the ability to self-renew. So that means that once that cell is dying, they can renew themselves and have more cells. And the second property is for the cell to be able to differentiate into different cell types or organs. So what that means is, some people like to call it the master cell. So what that means is you have the master cell, and then they can break into or differentiate into different cells of various body organs or tissues. Now, there are a lot of people, when they call stem cell therapies, actually not all the cells which are being used are stem cells. So like I said, the stem cells have to have those two properties to be able to self-renew and differentiate. What is probably a more appropriate term, and that's what we use in our research lab, is called cell therapies. So cell therapies, as opposed to stem cells, is those therapies which are, the transplantation or injection or, administration of human cells into a body or tissue which is damaged. And the property these cells have is their ability to repair, regenerate, or kind of protect. So I don't know if it's clear, but stem cells have to have those two properties of self-renewal and differentiation. Cell therapies don't need to necessarily have those properties. So I might give a cell therapy which is not going to differentiate, which is not going to self-renew, but it might produce some factors or some properties which help repair or regenerate or do something to those damaged parts. Is that clear, Diana? So that's very important thing for people to understand. So sometimes people say, I'm going to a stem cell clinic. They may or may not be actually using stem cells. They might be using biological cells, and biological cells are basically cells derived from the human body to repair, regenerate, or protect any organ.
Okay, that's very helpful, because in my brain, and obviously not being well educated on this matter, cell therapy and stem cells were kind of synonymous for me. So thank you for clearing that up. That's a big thing to know.
Yeah, so I would encourage people to think of it as cell therapies mostly, because most of the cells which are in clinical use or in production in preclinical use are actually not stem cells.
Okay.
So some of them are, not all of them.
And not all of them. Okay. If you could go over maybe the basic history of stem cell development, and after that conversation, maybe it's more cell therapy development if you want, especially in reference to understanding and treating HIE, that would be amazing.
Yeah, so I'll quickly go through the stem cell history very, very quickly, and then I'll come to HIE. So stem cells, in the 60s, people started to discover that there are these stem cells present in our bone marrow, present in our embryo, and so on. As you can imagine, we start life as a small embryo, and then through one cell or two cells, we start having different body parts being made. So that is stem cells. In the bone marrow, we have one starting bone marrow cell, which then differentiates into red cells, into white cells, into platelets, all the various cells which circulate through our blood, which protect us through infections, which protect us through bleeding and all that. They all start from those stem cells. So that's the background of stem cells. In the 60s, people started to discover that. Now, in the 90s or late 80s, people started to also find that some of these stem cells may be used to transplant into other human beings and protect them. And the biggest example of that is, again, for blood disorders and leukemias. So blood disorders and leukemias, as you know, most of the time involve those cells which are in our bone marrow or in our circulating blood, which are impaired or are excessively dividing. So the point was, if I transfuse someone else's stem cells or a related donor's stem cells from their bone marrow, it might protect them. So that's the evolution of the stem cell field. And to date, it is still the most common use of stem cells, blood, and blood related cancers. They still are the most common. Now it has evolved into other cancers, and you might have heard of newer types of cells being used for that, and that's where cell therapies comes into. So the stem cells, like I said, are not a lot. They are available in a lot of our body tissues, but what we have started to use now, and we and others and a lot of the other research communities have started to use, is cell therapies, which are using properties of those cells which may be useful, which I've just mentioned before, to repair and regenerate and protect. So when it comes to HIE, the history of cell therapies, like I like to call it, is probably less than 2 decades old. So it's not been around for a long time. Probably in the late 2000s, people started to explore the properties of these cell therapies in preclinical models, which is generally animal models or lab-based models in hypoxic ischemic encephalopathy. So there has been some progress into the clinical space as well, but there's a lot more work to be done. So it is promising, but it will be naive of me to say that we are, at the gate of something very exciting, ready to translate into the clinic. So I think we are getting there, but a lot more work needs to be done.
Okay. So, in spite of a lot more work needing to be done, why, in your opinion, are cell therapies or stem cells, why is this a promising field, and why might it be a valid strategy for treating a brain injury?
Okay. So when you say brain injury, there are many types of brain injury, and I'll just go back to perinatal brain injury. So perinatal brain injury is brain injury acquired during the fetal life, so in the womb, during the process of birth, which is most often where HIE occurs, in terms of, close to the birth process, a few hours, a few days before the birth, or a few hours, a few minutes after birth. That's where hypoxic ischemic encephalopathy mostly happens. And then there are other types of brain injury in the newborn period, which might be due to neonatal stroke, which might be due to preterm brain injury, due to intraventricular hemorrhage, and so on. So there's a lot to discuss here, but we'll try to focus our discussion to HIE. And when it comes to HIE, Hope for HIE and Betsy and the group have been working on this a long time, and they know that what generally happens in HIE is that it's a sentinel event. So there is something catastrophic which happens to the baby's blood flow to the brain at the time of delivery or around the time of delivery, which obviously then causes brain damage and potential lifelong problems. The issue becomes with HIE is that it is a very sharp and acute insult in most cases. In some cases, it might not be so sharp and acute. It is more long-standing for a few days, sometimes even longer. The damage sometimes is done so quickly that the chances of repair is limited because the window of therapy is limited. And that's where I would want to introduce the concept of hypothermia, therapeutic hypothermia, where we cool the body's temperature down by 3 degrees to normal in an attempt to protect the brain, is still the only proven therapy for HIE around the world. The problem with therapeutic hypothermia is that you need to institute it very quickly after the injury has started. And the second problem you have is that even if you institute it very soon, it does not protect everyone, because it is possible that in some cases the damage is so total or so widespread and so deep that even hypothermia cannot protect. So, at best, hypothermia protects 50% of those infants who have suffered moderate to severe hypoxic ischemic encephalopathy. So the field needs to look at other therapies in conjunction with hypothermia, which are going to protect the brain or protect long-term, brain function, but also consider for those situations where hypothermia wasn't available because you couldn't institute it early enough. The baby was born in a small regional hospital, hypothermia wasn't available, or something else happened. So access to hypothermia wasn't available. We need to think of other therapies. So I think that's our interest, and that's been the interest of a lot of researchers around the world, trying to improve those options for hypothermia, for hypoxic ischemic encephalopathy. What is another interesting point about HIE is that when we do studies on preclinical models, these are lab models, or something which is more upcoming nowadays is brain organoid models. So we don't need to do it in an animal, because animals obviously are not very complex, but they are not exactly human, beings. So it's never completely translatable. But the other thing is, if you actually start growing those tissues in dishes, which is called, a brain in a dish kind of model, we can look at those therapies in a much different way. These are called in vitro experiments. So we are actually able to study those therapies in a preclinical space in the lab or in the animal model. And what is interesting about HIE is because there is a definite time when the insult happens, we can mimic that insult in a lab or animal model as well very closely. That makes sense. So it is actually one of those conditions, because the timing is well known in most situations, we can actually check or assess, evaluate how those cell therapies which we are developing, which we're testing, are going to work. So it's quite promising for that reason. There's a clear-cut event which happens, which you can study.
Wonderful. Thank you so much. You mentioned that, because hypothermia, as you said, is perhaps only 50% effective in most patients, and that's kind of what drives this research forward, is that there needs to be some type of cell therapy in conjunction with it. Is that kind of a motivating factor behind your own research? I'm just, before we get into the next question, I'm just curious about your own passion and your own reason that you are so interested in this work.
And that's a good question. It's always personal passions which drive, our group and drive our research. So, see, I'm a neonatologist, and I've been a neonatologist for more than 15 years. And for the first 5 years of my practice, I was a full-time neonatologist. And during that time, I noticed two things. One is that, we are really good in, helping most of these babies survive, whether it's babies with HIE, which is, I would say still a small proportion of the problems we see in the high income setting. HIE is a big issue in the low and middle income setting, but in the high income setting, although it is devastating, it is still not of a huge proportion. The bigger burden we see is preterm birth. Premature birth causes much more of a burden in terms of brain injury and the long-term problems as compared to HIE in the high-income settings like the US, Australia, and Europe. So my work basically focused on two things. One, I could see that we are really good in keeping these babies alive, and survival is really good for all of these high-risk situations, term HIE, preterm babies, and so on. Their outcomes haven't improved from a long-term outcome point of view for almost 2 decades. So for the 2 decades since I've been in neonatology for 25 years, and over that time I've seen we are really good at keeping these babies alive, but unfortunately their outcomes, when it comes to long-term outcomes of survival and what we call intact survival, which means survival without disability, hasn't improved a lot. It has got a bit better, but it's not improved a lot. So I knew that I can continue like this for another 30 years and probably not much will change. I was keen to do something to improve their outcomes from that space. I also so that was the research aspect of my work. The other was the education aspect. So around the world, around 1 million babies, I don't know if you know, die every year due to HIE, and most of them are in Africa and Asia. Around 1 million babies die every year because of hypoxic ischemic encephalopathy or birth asphyxia or perinatal asphyxia related problems. And most of them are actually preventable. And that's where education comes in. So while I was doing these research in our lab groups and with our scientist colleagues, I also started a program called OneSIM Education, where what we do is we try to educate the healthcare providers in these low income settings to improve the detection of problems in the mother, and then the care of the baby once the baby comes out, if those problems could not be mitigated enough. So the idea is, if we can prevent HIE, we don't need to worry about treating it. And the best way to prevent HIE is to be able to monitor those mothers who are high risk, but also sometimes mothers are not high risk. They come into labor and then suddenly something goes wrong. The cord snaps, the cord gets entangled, something else happens, the placenta abrupts, and the baby suffers from HIE. So the idea is to be able to help those healthcare providers pick up those problems. So I think with anything in life, there are two aspects to it. Great clinical work, but then great education and research to go along with it. And that was my personal driving force. I could do the clinical work as good as I like, but if I don't concentrate on the education and research to improve these outcomes, it's not going to do much. So, and I'm not saying I'm just a drop in the ocean of the research around this, but hopefully with all our work together, we can make a difference.
Yeah, well, and with organizations like us, I mean, we obviously so appreciate all that work that you're doing. Just like we're also all about advocacy and education and awareness. So thank you so much for all of your contributions to that field. In terms of the current state of the research, I know you kind of started talking about it. Maybe you could talk about your own personal and institutional research about cell therapies, and then if you have an idea, branch out into a more global summary of what's going on in certain pockets of research in the world.
Yeah. So it's a very good question. So, doing research for these kind of cutting edge or innovative research requires a lot of setup and needs a lot of infrastructure to be able to do it. And as you can understand, a lot of money. So, we depend on government funding for our research. We depend on a good infrastructure and university lab support, hospital support, you name it. You need a big, like they say, it takes a village to do these kind of things. So it is a big enterprise. And we are fortunate to be in one of the most I think, exciting and advanced perinatal research institutes in Australia called the Ritchie Center, also part of the Hudson Institute of Medical Research, which is part of Monash University, and we are all on the same site. So actually, we are in a hospital space. Within a few meters, we have our lab spaces, and we have all the facilities available. So it is a very fertile ground to be able to do this research. And one of the interests of our group, our lab, and our institute has been to be able to do research from bench to bedside and in the same site. So what happens is you can do the preclinical work, the lab work, the animal work, and then the human work all along the same site. And that's really critical as we develop these therapies, because sometimes it's bench to bedside and back to bench. So you learn what in the lab, you take it to the clinic, and from the clinic, you take it back to the lab and work around it. So I think that's the strength of our work. One of the other things which I want to mention is, and which may come again later on in our discussion, is that a lot of people do work on small animal models because they are easy and easy to rear, easy to look after. And the commonest animal model used for some of this work is the rodent, the rat or mice models. And the Rice-Venucci model is the most common model. Basically, if you block off one of the big arteries going into the rat's brain, it's going to produce a kind of a condition similar to HIE. It's not exactly similar because we are not similar to rats. So it's very difficult to say that what we see in the rat is going to be applicable to the human completely. But one of the spaces which we fill in very well is we not only do rodent or rat research, we also do sheep and bigger animal research, bigger animal model research. And the larger the animal, the more closer it is to the human. And that's a really important point, because when you look at the studies which have been done on a lot of these cell therapies, or for that matter, any therapy for HIE, for any condition, most of them are done in small animal models. I think before you move from proof of concept studies from the small animal model to the human, you need that large animal studies as well. And like I said, it's a circle. You take back what information you get from the early studies back into the lab, back into the animal model, and back into the lab in vitro models, which is like what I talked about, the dish. So I'm very privileged. I'm very lucky to be able to work in this space. I did my PhD in this space, and my PhD, although I'm a clinician, was completely preclinical. So I did not work with babies or humans. I worked with animals and in the lab. And that taught me a lot of things. That taught me the respect, we need to have for all the science behind this, because science is really important. And if you look at the only intervention which is available for HIE, Diana, right now, which is hypothermia, that also started in the animal or lab space. In fact, by my very good friend and colleague, Alistair Gunn in New Zealand. So, Australia and New Zealand has always kicked above their weight in a lot of things, and research is one of those. So that is our work, and we are looking at all different kinds of perinatal brain injury models when it comes to not just HIE, preterm birth, fetal growth restriction, which is when a baby is born smaller than expected, inflammation, all those things which cause brain injury in the newborn baby is our focus. So we have a number of PhD students, scientists, and research assistants helping us on that. The other groups which are quite active in this are in the US, in Europe, and in Asia. And I would just mention a few of them. Joanne Kurtzberg group in Duke, Charles Cox group in Houston. They have been very active in this area when it comes to perinatal brain injury and cell therapies. There is a group in Netherlands led by David Lay. There's a group in Denmark as well. And then there are groups in South Korea, China, and Japan. We are actually in close contact with most of those groups. So it is a niche field. As you can understand, you need to have the right ground to be able to do it, the right infrastructure. But there's a lot of exciting work happening all over, and we talk to each other because there's no point trying to compete with each other or do similar work when we can join hands and do it together. So there's a lot of excitement happening there. And recently we had our first neonatal cell therapy symposium in Melbourne, which we hosted, and we brought together a number of experts from around the world to discuss this. So I think there's a lot happening, and I would love to say that we are almost at the brink of doing a lot in terms of human translation, but we're getting there. We're getting there.
Wonderful. I know in some of our preliminary discussions, you mentioned that there are a lot of different types of stem cells. So when it comes to treatment of brain injury, particularly, I know you said there are several kinds for HIE. Which of those stem cells have you found are maybe the most promising?
Yes, it's a very good question, Diana. So, there are two words which I would like to clarify here. One is promising, and the other is where are they in the pipeline? So there are two different aspects to this. So promising means that we are seeing the best benefits in the lab, and what is most advanced in the pipeline means which is closest to clinic or clinical use. Okay, and what is closest to clinical use doesn't necessarily mean that they will be the best or most effective. So we need to keep that in mind. So there are a number of cell therapies which are being in use, and like I mentioned before, some of them are stem cells. So the commonest cell therapies or stem cells which are being studied in the lab are cells which are derived from the umbilical cord or cord tissue. So what that means is, the umbilical cord is a lifeline in the womb, and when a baby is born, soon after birth or a few minutes after birth, it's cut, and with the placenta, it's disposed of. That umbilical cord and placenta is a very rich source of stem cells and cell therapies, or cells which can be used for cell therapies. So I think that's probably the most advanced in the pipeline for use, and you can understand why, because it is in most cases we are using those cells, those stem cells, from the baby's own placenta or cord blood or cord tissue. The problem with those is so that's the advantage, that it's the baby's own, so it's and it's, sorry about this.
We'll wait for you. We got nowhere to be. Good.
Yeah. So the umbilical cord is the baby's own, so there's no question of using a foreign tissue or something else in that space. So the cord blood and the cord tissue, if people remember the umbilical cord, it has got blood vessels in it, but it's also got very jelly-like substance called the Wharton jelly, or the cord tissue around those blood vessels. Both of those are good sources of stem cells and therapies which can be used as cell therapies. So our group and a lot of the other groups have been working on those cell types. So that's you can say the most advanced in the pipeline. And we have actually 3 cell therapy trials in humans running currently using umbilical cord blood or cord tissue at Monash. Now, none of those trials are for HIE itself. We are doing it more for preterm brain injury, or for another brain injury called neonatal stroke, which is when the baby has suffered a significant insult to one part of the brain, but it's not necessarily related to the hypoxic ischemic encephalopathy, which happens during birth asphyxia or perinatal asphyxia. Okay, the other group which has been using cord blood for HIE has been the Duke group, which I mentioned before, from Joanne Kurtzberg, and they've done actually 2 trials already on this. One trial which was published many years ago in 2014, led by Michael Cotton, where they showed the safety and feasibility of using the baby's own cord blood and the cells derived from that for HIE, and they showed some promising result at the start. They tried to replicate it in a bigger trial, which is still not published, but unfortunately they had to stop recruitment because it is a difficult trial to do. As you can understand, I cannot predict which woman or which baby is going to have an HIE beforehand. So to be able to get to that baby, to get enough cord blood from there in a rush is quite challenging, and like I said, although perinatal asphyxia is an important and relevant condition, it's luckily not so common in the high income setting. So to get access to a lot of these babies with the right facilities available to actually process these stem cells or cells from the cord, you need a setup. So if someone delivers, you get the cord blood from there, you process it, and then you we harvest the cells which are relevant and then give it back to the baby. Because as you can imagine, blood contains a lot of cells. It contains white cells, it contains red cells, it contains plasma, and a lot of things. So what actually happens with cord blood stem cell therapies is we actually process it down, where we spin it down in a centrifuge, and we separate the blood and the plasma, and in between the blood and plasma is what is called Buffy coat, and the Buffy coat contains the most important cells which we think will help with repair of the brain. And to get that, you need a facility, so to be able to do that in an easy manner, you need a lot of infrastructure. And like I said, it was a difficult trial to kind of get access to. In Monash, for example, in Melbourne, we have less than 10 babies a year who have HIE. So 10 babies a year. If I try to do a trial which is requiring 200, 300 babies, it'll take me many years to finish it. And even in those 10 babies, not all of them might have those cord blood readily available. So there are a lot of challenges with that, and that's why we are focusing our work for the cord blood aspect of it on preterm babies, because they are more predictable as compared to HIE. Around close to 10% of babies are born preterm, and more than around 2% of them are born extremely preterm out of those 10%. So I think that's a much more readily use of the cord blood. The other cell types which are being considered for HIE are cells which are derived from other organ tissue, especially the bone marrow. So the bone marrow has a rich source of what is called bone marrow derived mesenchymal stromal cells. These are a type of stem cells. And a lot of other groups, including ours, have been looking at what is called induced pluripotent stem cells, which means that the cells do not have a you can say stem-like property to start with, but you can induce them to produce that. Pluripotent means the thing which I talked about at the start, the ability to differentiate into different organ tissues or types. So those are being done, but it is actually manipulating that cell. So there is a bit of ethical issues in there, because obviously you are manipulating those cells, and for those cells to be used in humans, especially for vulnerable, very young babies, we are not quite there yet. So those are the things in the pipeline. There has been a group in the Netherlands which recently did a trial of using those cells by putting it in the baby's nose, so delivering it via the nasal passage. And the idea is that the nose is close to the brain, so it is going to be much more effective in reaching there. So they've done a safety study in stroke, so in perinatal stroke, not in HIE, but in perinatal stroke. And it's promising, and we'll have to watch this space if that works. So those were cells derived from the bone marrow. They were not induced, they were bone marrow stem cells derived and used. But what happens in many of these stem cell kind of applications is that we produce a very good quality of bone marrow and keep reproducing them so that we can use a cell type, a cell source, which is clearly identified and we know what we are giving. And that's a really important point, because sometimes people go to these so-called stem cell clinics and you don't know what they're actually giving. So, the FDA has got a very important, warning about those things, that people need to do their research properly. And sometimes, obviously, the community does not have time or does not have the, resources to do that. So I think it's very important to know what cell type we are using and what is happening there. So if I can just summarize on the HI field around the world, cord blood is one of those cells. Bone marrow derived cells is another type, and then the last one is the induced pluripotent types. Now there are other cell types also there, like placenta and from other tissues, which are all at a more preclinical stage instead of clinical pipeline development.
We did have a relevant question in the chat come in. And they asked, do you have to use fresh placentas or can you harvest from frozen?
It's a very good question. So, I'm not aware of many places who are, freezing their placentas routinely. And if you did that, you would need to follow some protocols. So any blood product or any, let's say, cell therapy product which is given to a human being has to go through a processing facility, which is FDA approved. In Australia, it's called TGA. It has to be approved by the regulatory authorities. So, for example, if I go to give blood and I encourage people to donate blood, you will have to follow a particular process for it to be stored and processed, for it to be used in other humans. Same applies to cell therapies. We need to follow that process. So if someone says, I delivered a baby and I froze my placenta, I'm not really sure that placenta is going to be easily accessible for that. If it was stored or frozen for the particular purpose which we are talking about, it's a different matter. But I'm not aware of a lot of people doing that currently. of extracting cells from frozen placentas. What they might be doing is we have programs where we have placenta and cord blood collection done as part of research, and people's placenta or their cells are extracted from the placenta and stored. Does that answer your question? Basically, what I'm saying is it has to be really thought through process. You cannot do it retrospectively that I've frozen it somewhere and now can I use it. I think that's not going to be appropriate.
Got it. Now you mentioned cord blood, and you mentioned also kind of like nasal administered. I'm wondering about the timing of that.
Oh, yeah.
And how does timing in terms of administration come into play, and does it differ depending on the type of where you got that stem cell?
It's an excellent question, Diana. So timing is really crucial. So I'll focus my discussion on HI because we are meeting today about HI, because I could keep talking about the timing in different conditions. So with HI, like people know, there's a primary phase where you have the insult, the acute phase of the insult, and then you have a secondary phase where the brain tries to repair or kind of cope with the insult, and then there's a tertiary phase. During the secondary and tertiary phase, the insult continues to evolve or develop. And hypothermia is used in that secondary phase, basically to avoid, if I lose blood to my brain suddenly, my brain will try to get that blood back. And when the blood comes back to the brain, it actually causes further insult because all the toxic inflammation which is happening is getting worsened by all that blood rushing through. And hypothermia basically works on that. If you drop that blood flow to the brain during that time, it will probably keep things at bay. That's the very simple kind of explanation of how hypothermia works. Now, stem cells or cell therapies in that HI space could be given at the start of the injury, could be given in the middle while hypothermia is happening, or after hypothermia has finished. So you could use it at various time points. We personally feel that it should not be given at the start, because what many of these cells do is, and I can just touch upon how these cells work. These cells work through a variety of factors. So the ideal stem cell, which are not very commonly used, like I said, more are cell therapies, are the ones which engraft, which means that I give a cell, and just like an organ transplantation, they go and stick to my body in the brain and they start regenerating or repairing tissues. There are not many cells available like that. The closest cell for that is what is called neural stem cell. So what that means is I give those cells, it goes to the brain, or I put it in the brain, transplant it into the brain, and then it starts to self-renew and regenerate. Neural stem cells has got a lot of ethical issues, because that means basically a brain is being formed within a brain almost, so it's still at an early stage of development. It's very exciting because if we are able to actually repair brain tissue, we could give it at any stage. We could give it to a child at 5 years, 10 years, even later, because that brain injury is there. We give cells which are able to self-renew and regenerate. But the risk you can understand with any engraftment is that it could be rejected, which means a major catastrophic reaction might happen. It could have tumor formation because you expect them to differentiate, but what if they start differentiating and dividing too fast? So there's a lot of concerns, and that's why it's not a therapy which is used currently. But we are working, or not just us, many people are working on trying to make it much easier or more controlled in that space. So that is, sorry about this.
No, it's okay. It's okay.
Pediatric respiratory.
Okay, so that was about those cells which could be given very late. Okay, that is not in clinical use at the moment. I don't think it will be in clinical use for a number of years, because we need to get the protocols right to avoid the adverse effects which might happen. What is more exciting and more likely to happen is that we give those cells at the end of hypothermia. And I would just like to spend 1 minute on hypothermia. So, when we do hypothermia, we're dropping the body's temperature. Most of the, research which has happened on these stem cells and cell therapies hasn't been done in conjunction with hypothermia. So people test it in the animal model, in the dish, wherever they test it, they are not actually exposing the animal or the brain to that lower temperature. So I'm not sure if those cells which they've tested are going to be effective when they give it in conjunction with hypothermia. And I'll give you an example of that. The community might have heard of the recent HEAL trial led by people in the US. The HEAL trial was testing erythropoietin, which is a kind of an agent which is produced by the body to see if it improves outcomes of HIE infants. It did not. And I think one of the problems again was that it is in conjunction with hypothermia. So we need to test those therapies, whichever therapy we are evolving or developing, in conjunction with hypothermia. And you can imagine hypothermia in animal models is not easy to replicate, but more importantly, people need to make that concerted effort to have those protocols along with hypothermia. What we have discovered in our time in our lab here is that these cells probably might be better once the hypothermia period is finished. So hypothermia generally is used for 72 hours after the insult. So after 3 days of the baby's life, that's probably when I think my money would be on when these cells should be used. Now, there have been trials, which I mentioned previously, which have given cells during hypothermia as well. And there are both challenges for the trial to actually progress, because that means you have to do it in a very quick manner in the first day or so of life to commence those cell therapies. But also, I'm not sure if they're going to be completely effective. So we need to have more research on what is the best timing. But there are the 3 timings, Diana. So in the first couple of days, after the first 3-4 days of life, or then at any point after that, because once the brain injury has occurred, there is still some hope to rescue some of that brain injury, but we need to work on those cell types to ensure. So there is some groups around the world are doing what is called an expanded access program for cord blood therapies for children with cerebral palsy and conditions related to HIE, which is promising, but more research needs to happen there as well. So it can happen at any timing wise, it can happen at any time, but we'll need to watch this space.
Got it. I know in our notes, I said we were going to jump to early detection measures of cerebral palsy, but it just makes sense to me right now to kind of, because you've already spoken about it a little bit, to segue into clinical trials. And are there any recent or current clinical trials with that word again, promising findings that you think our HIE community would be interested to hear about?
Yeah, so there are a number of trials running across the world. The best way to look at is a clinical trials registry. So there is a clinicaltrials.gov in the US and similar registries around the world, in China, in the Europe, and in Australia. And if you look at those registries, you'll see that there are a handful of trials for HIE which use cell therapies or stem cells. Some of them use the cord blood I mentioned. So the cord blood is the most advanced in that field. There have been trials in the US which have shown the feasibility and safety of it. There have been trials in Japan which have shown similarly. So there have been 3 or 4 publications on this already, which have shown the safety and feasibility. What the community needs to know is the efficacy. For doing efficacy trials where you actually show that they actually are beneficial, it's fine from a safety point of view. You give it to them, there's no harm done. But from an efficacy point of view, you need a number of babies. You need a bigger population. You need generally more than 200, 300 babies to do that. And for that to happen, you need multi-centers, kind of trials to work on that. So as far as I'm aware, there's no big trial currently recruiting, but there are small trials still working on small kind of modifications to the protocol to see what might be the most beneficial timing, what might be the most beneficial dose, and so on. So that is cord blood. There is there are trials on the mesenchymal stromal cells I mentioned, MSCs. So MSCs can be derived from the cord tissue, can be derived from bone marrow, can be induced. So so they are a very promising cell type which is in mass production for a number of conditions in adults, in babies, in children, for a number of things. And in babies, obviously, HIE is one of them. There are a small number of trials for that cell type also currently undergoing, research and in human trials. But we don't have something coming up. I would love to tell the community something is coming up very shortly. Nothing coming up immediately, but the last one which published was the nasal administration of those cells for stroke. So wasn't HIE, but for stroke in the neonatal period.
How do people find out about clinical trials and when they are coming up, or if they are coming up, and when to get involved if that's an option for them.
Yeah, I would love to give you a one-stop shop for these kind of things, but unfortunately there is none. Yeah, I think groups like yours, Hope for HIE, and there are cord blood groups and placental groups called Save the Cord Foundation and umbilical and placental cord, stem cell foundations, which regularly propagate, and people can sign up for their newsletters. Whenever you sign up for those things, just make sure that they are completely regulated and they have got a statement about their information which they provide, because you don't want to be dealing with unscrupulous authorities dealing with those information. But the best resource, I think, in most cases is your doctor or your nurse or your healthcare provider generally would have good information, because what we do, what Hope for HI does, and what a lot of the organizations do is that we keep in touch with all the leaders in the space. So a good hospital, a healthcare provider should be able to tell you what is ongoing in your center in terms of trials for those, and that's how medicine advances. If people participate in those trials, which are generally FDA approved, which are regulated by ethics bodies, which are very carefully controlled, and then information whether the trial is negative outcome or positive outcome is published, that's really important, because there's the concept of publication bias. People only publish the positive results and don't publish the negative results. I think that should be fine. For example, we are collaborating with our collaborators in the US for running our next phase of trial for our preterm brain injury trials. So that's how so if a baby is born in, let's say, Texas or somewhere else, they will know that there's a trial going on for this particular condition, and that's how the field advances. I would love to say again that we are close to something in standard clinical use, but just to give you an example of therapeutic hypothermia, it took around 10 to 15 years before it came into clinical use. Once people started to find out that it is probably going to be efficacious. So it takes a decade or so for that to be put into clinical use. But by participating in trials, the baby's outcomes are going to be better. We know this. Whether you are randomized into the intervention arm or control arm, it doesn't matter, because end of the day, you will be going through a very controlled, regulated kind of framework to look at their outcomes. And generally, we know that outcomes are better if you're in a part of research trials. So I think I would encourage people to look into their local hospital and healthcare providers.
Thank you. I think now is a great time to kind of switch over and talk about early detection measures of cerebral palsy. I know that's something that you've done research with too. And as you know, it's one of Hope for HIE's goals to arm people with information when it comes to advocacy for early detection of cerebral palsy. So I guess my question for you is, do stem cells or cell therapies, do those relate to work with finding out early detection measures for cerebral palsy, or are those two things unrelated?
Oh, it's an excellent question, Diana. So, my work, so I lead a clinic called the Early Neurodevelopment Clinic here at Monash. And the idea is for babies who are born under high-risk situations, whether premature, born through HIE, born through any kind of brain injury, we want to assess their neurodevelopmental outcomes or, their development as soon as possible after birth. And this is very well evidence-based. So in 2017, an international group of researchers in the neurology brain space for babies and children came together and produced this guideline document, which said that in the current scheme of things with standardized assessments, which I'll get into briefly in a minute, we are able to detect or diagnose children with cerebral palsy or with significant developmental problems very early, as early as 3 months of age. So, cerebral palsy, as your community might be aware, is obviously quite a devastating condition for some children. It's a broad condition which varies in the severity, but it is a lifelong condition which impacts their brain motor function, mostly motor function, which is their physical ability to move around, or their posture of how they are kind of, their body is responding to various cues. Used to be diagnosed more at 1.5 to 3 years of life. Nowadays, with those standardized assessments, we are able to diagnose them as early as 3 months post birth. And you can imagine, if I am able to diagnose a child who's got a risk of cerebral palsy at such an early age, I institute physical therapies, interventions, early childhood intervention for them at 3 months of age as compared to 2 years of age, their outcomes are going to be better because the brain is much more plastic. Plastic is a lay term for basically saying that we can mold the brain, we can teach the brain to do better with whatever resources it has if we detect that early. And we have been running this clinic for 4 years and we have some excellent outcomes on that. So if people search up my name or early detection of CP, you'll see a lot of resources on this. And what we have been doing is institute that early intervention in those families, and families come back to us and tell us that how amazing it has been. And this is well researched, so we are doing it as standard of care here in Melbourne, but this has been researched, and to come to this point, it has taken probably around a decade or so of research which showed the benefits of that early detection. The benefits of early detection are not just for the baby and the family, but for the community as well. You save much more tax-funded dollars if we institute those therapies at an early stage instead of at a later stage when the problems have become so exacerbated that actually you need much more money to be spent to improve those outcomes. So I think it's very closely tied into my work, because for these therapies which we are trying to test and evaluate in humans with early phase trials to show benefit, I'll be able to see those benefits at a very early age when it comes to motor outcomes, physical outcomes. So it's closely tied into that. So all the studies which we do using stem cells or cell therapies have got that early phase assessment included in the protocol of the study. And because it's standard of care, it actually is not an extra burden on anyone, whether it's us or the families, because we are already doing it for these high-risk babies. That makes sense. So basically, if I can reiterate, early detection is key for good outcomes for not just families, babies, and communities, but also for research so that we can evaluate the benefits early on. The only caveat is that when you look at early development for these babies, this is really early, 3 months or so, we will not be able to get a great assessment of all of their developmental outcomes. We cannot get any idea of learning for the baby, their long-term learning outcomes by looking at them at 3 months, or their behavioral outcomes, how they're going to have problems of autism, attention deficit, or whatever else at that early stage. But we get a really good feel of their motor outcomes, their physical impairments, which they may be at risk of. And we try to change the trajectory for that by early intervention.
So early intervention requires an early diagnosis, but an early diagnosis means that, there is a provider who has to, provide that. But in your professional opinion, because I know you mentioned there are moments where a kid may not be diagnosed officially until 1.5 years, 2 years of age. Why maybe do some physicians wait or prolong an official diagnosis of CP?
Okay, it's a great question, and it's a slightly controversial question as well, probably.
I know, I know.
I think it comes down to, Diana, it comes down to education. Just like the community needs to be educated, the healthcare providers need to be educated as well. Whether it's the low-income setting where we are educating them about good obstetric care and neonatal care, I think a number of my colleagues around the world still are, kind of averse to the awareness of early detection. And it's through portals like this for communities, it's through conferences, it's through updates for those health providers to be aware of that. When we started our clinic, many of my colleagues were not sure that it's going to be very effective, but then they started to realize, no, it's absolutely amazing. So, so I think it's about awareness. It's true for our healthcare providers. It's for them to look at the research which is coming out of there. Also our real world experiences. So, we have been publishing the real world experiences, obviously completely de-identified and ethically, approved in terms of how these babies are doing with these early detection. And then, so looking at papers, coming to updates looking at various resources. So, the more we talk about it, the more awareness it is. And what we do now is that we do a session for our nurses and doctors in training. So while they are medical students, they're nursing students, we talk about them there. We talk about it to the general practitioners, the family care physician in the US, so we talk about to everyone so that they are aware and they would check with their, specialists whether this child can be assessed for early detection of cerebral palsy, or it's not just cerebral palsy, any motor problems. So sometimes you have cerebral palsy, but sometimes you might have what is called developmental delay, where basically the child is not sitting or walking or standing at the right time. So you want to be more aware of that and make that diagnosis of severe delay, significant delay, which requires early intervention. And if I can just quickly mention on the fact that, when it comes to Australia has been leading on this space, and what we are hoping in the next few years, we have a parent and patient advocacy group called Cerebral Palsy Alliance, which has also got a North American arm, and we are advocating for routine testing or surveillance of cerebral palsy at 3 months of age for every child, not just high risk. So currently I'm running a program where we look at infants who are born through high risk pregnancies, but not every child with cerebral palsy has got a high risk pregnancy or a high risk birth associated. Sometimes you have a completely normal start to life and then you have cerebral palsy. So we are advocating that just like we have the newborns screen blood test done for number of genetic and metabolic problems, we could do the same for cerebral palsy. If we start detecting them early on, we'll be able to do more for them. So these are infants who may not be born through a high risk situation like HIE, right. Any infant. Right. So just like you would get to your doctor for a normal immunization check or a health check, you could do similar for cerebral palsy. So it's very exciting. So let's see if that evolves, because it's still not standard of care, but we are hoping we'll be able to do that at some stage.
Yeah. As we close out our section on cerebral palsy, and then we're really close to finishing this Q&A, is there any other important information you feel like it's pertinent for our HIE community to know when it comes to early detection for CP? I know that you've mentioned, early intervention and early diagnosis is key. Is there anything else that you would like to add to that list?
Yes, not particularly from a cerebral palsy detection point of view, Diana, but I do want to mention something. I've got a colleague and friend called Anup Katharia, and he did a big study recently across many countries, which looked at babies who are born in poor condition, and HIE is one of those. So basically what happens with HIE, as you know, is the baby comes out flat, looking depressed, not moving much. And I don't want to bring back memories for some of those parents who've had those situations, but they're in quite dire circumstances at the time of birth. And what Anup and his group did was that they tried to look at something which is very close to our heart, where basically they tried to milk the umbilical cord into the baby. So what milking means is that when the baby is born and is not looking very well, what people do is quickly cut the cord and move the baby to the doctors and nurses to look after in their resuscitation. They try to resuscitate the baby and improve their outcomes from a breathing and heart point of view. What they showed was that by milking the cord, they were actually able to drop the rates of HIE. So it's almost like a secondary prevention. The primary prevention is avoid HIE. No baby has HIE, but in some situations we can't avoid it. But by milking the cord, they were showing that the HIE was less, and probably their outcomes will be less as well, because they still have to do their 2-year and 5-year outcomes. But this is very close to us, because we think what we do from the cord blood when we try to get cells out of them is probably similar to what happens in milking, but we are concentrating those cells and giving it back to the baby. By milking, you're giving the whole cells and the volume of blood along with it as well. It's baby's own. But by doing that, very quickly, within few seconds, you're milking the cord and giving it to the baby. And I think it's closely related to what we are doing in cell therapies. Why can't we just do milking for every baby? Because it's not always possible to have cord ready, because some of these babies, the cord is so damaged and so obliterated almost at the time of birth that it's not possible. But I just want to mention that this is an interesting development which is going to have I think far-reaching consequences all over the world, because it's going to be a very readily used therapy, which is associated, we think, with the stem cells and the cells which are transplanted when we're doing the milking.
Wonderful, thank you. We just have one last question we love to ask our experts at the end of each Q&A. Do you have a resource or some resources that you would recommend to share with families, or think families should know or be aware of when it comes to development of cell therapies for HIE?
Yeah, so I don't have a specific HIE resource of our own, but I mentioned some of those other groups which people can follow. Your obviously Hope for HIE, Save the Cord, umbilical and placental cell news, those kind of group. There's a stem cell network as well. So I'm not sure there will be specific HIE news, but if they can also follow our developments on our neonatal cell therapies page, which is easily accessible via any search engine. We have a Twitter page, we have a website, and we keep updating what's happening in the perinatal brain injury space. So it won't be focused on HIE, but it will be the developments which we are making, and we try to put in other information on whatever is coming up in the space of cell therapies across the world. So, I would, like I said before, I would love to have a very good resource, and maybe we need to develop that as we develop some of these therapies more in the future. But currently, I don't have a very good resource.
Well, you just listed 4 or 5 wonderful recommendations, and as far as I'm concerned, that's 4 to 5 more than I had a minute ago. So thank you. And that concludes our Q&A. I believe you answered most of the questions that came in the chat. Just to reiterate, we're so unbelievably grateful for you taking the time and accommodating the vast time difference and just offering your knowledge and expertise. It's really meaningful for obviously me and Betsy, but more importantly, just for people involved in this community. So a million thank yous for everything. And we can't wait to see the future of all of this research. And again, grateful for your contributions.
Thank you so much, Diana, for the opportunity. And hopefully I'll come back in a couple of years or even earlier, hopefully, and tell you if there is some advance which is happening for the HIE community. There are a lot of other therapies which are in the mix. We are working on therapies which we could give even before the baby is born to supplement the mother. There are therapies which we are working with collaborators in the UK, where we are looking at therapies like melatonin to give along with hypothermia, which could improve things. So cell therapies obviously is exciting, but we have to keep working at a lot of different angles to see what works best for these children, because they have a great future. I see some of the HI kids do fantastic, and we just want to make their future even brighter. So we don't want to give those families the best chance, best hope for a great future for them. So thank you so much for having me.
Oh, thank you so much, and thank you to everyone for joining our live session. This will be downloaded and will be uploaded again across all of our social media channels, as well as YouTube in a couple of days, as soon as I upload it and create the closed captioning. So thank you to everybody, and thank you to you again.